The clinical management of systemic arterial hypertension relies on a specific objective: the precise modulation of peripheral vascular resistance and endothelial cell reactivity. Within clinical nutrition, specific dietary fruits serve as pharmaceutical-grade delivery vehicles, carrying the precise biochemicals required to manipulate cellular pathways. These interventions target two primary mechanisms: the electrophysiology of intracellular electrolytes and the bioavailability of endothelial nitric oxide. The clinical efficacy of these biochemicals is strictly limited by physiological barriers. Before any active compound can affect vascular tone, it must survive the gauntlet of intestinal absorption and first-pass hepatic metabolism. Because these dietary interventions operate via highly potent biochemical pathways, they carry severe pharmacological and nephrological contraindications. When introduced to compromised metabolic environments, they require rigorous risk stratification. Dietary fruit is a complex matrix of active compounds that demands precise mechanistic understanding to prevent systemic failure. In state-specific salt-sensitive hypertension, impaired renal sodium clearance causes sodium to accumulate in the extracellular fluid. This expands plasma volume and directly elevates systemic vascular resistance. We can measure this nutritional imbalance through elevated urinary sodium to potassium ratios, an objective biomarker that directly correlates with elevated arterial pressures. To correct high vascular resistance at the cellular level, we rely on dietary potassium powerhouses like bananas, kiwis, and avocados to stimulate the membrane-bound sodium-potassium ATPase pump. An increase in extracellular potassium triggers an unequal stoichiometric exchange. The pump actively exports 3 sodium ions from the cytoplasm while importing only 2 potassium ions. This net loss of positive charge drives the resting membrane potential into a negative state, hyperpolarizing the cell. The shift in electrical charge forces voltage-gated L-type calcium channels on the cell membrane to close, completely halting the influx of extracellular calcium. With cytosolic calcium depleted, the activation of myosin light chain kinase stops. As a result, the smooth muscle is forced into a state of profound relaxation, physically dropping the peripheral vascular resistance. The clinical validation of this exact electrophysiological pathway was provided by the Oslo antioxidant study, which monitored 118 mildly hypertensive adults. Over 8 weeks, the addition of just 3 kiwis daily reduced 24-hour ambulatory systolic blood pressure by 3.6 millimeters of mercury and diastolic pressure by 1.9 millimeters. The clinical value of dietary potassium lies in its role as a direct electrophysiological trigger, deactivating the vascular smooth muscle contraction cascade at the membrane level. Looking at the interior of an endothelial cell, we see a parallel vasodilatory pathway. Here, endothelial nitric oxide synthase, or eNOS, continuously synthesizes highly diffusible nitric oxide gas from the amino acid L-arginine. The nitric oxide rapidly diffuses into the adjacent smooth muscle cell, where it binds to soluble guanylyl cyclase. This catalyzes the production of cyclic GMP, a potent second messenger. Elevated cyclic GMP directly inhibits extracellular calcium entry and activates myosin light chain phosphatase, preventing myosin heads from forming crossbridges and forcing the muscle to relax. To amplify this pathway, patients often attempt to consume L-arginine. However, they encounter the L-arginine paradox. Orally ingested L-arginine is heavily degraded by arginase enzymes in the intestinal wall and liver before it ever reaches systemic circulation. L-citrulline, an amino acid heavily concentrated in watermelon, provides a molecular bypass. It successfully evades first-pass hepatic metabolism and circulates directly to the kidneys. Once in the renal system, the enzymes ASS and ASL convert this intact L-citrulline directly into bioavailable L-arginine, providing the exact substrate eNOS needs to synthesize nitric oxide. This split-screen chart illustrates the delivery challenge of this molecular bypass. You would need to consume over 1 kilogram of raw watermelon daily to generate a sufficient spike in systemic L-arginine. Without advanced manufacturing technologies like microencapsulation to compress a therapeutic 4-gram dose into a 30-gram serving, raw watermelon fails to provide sufficient L-citrulline concentrations to improve arterial stiffness in older adults. Even with sufficient substrate, this cascade faces a secondary threat. Oxidative stress can uncouple the eNOS enzyme by oxidizing its critical cofactor, tetrahydrobiopterin, or BH4, into BH2. Anthocyanins, the water-soluble flavonoid pigments found in berries, act as potent radical scavengers. They protect the structural integrity of BH4, ensuring the enzyme continues synthesizing healthy nitric oxide instead of destructive superoxide anions. Delivering vasodilatory precursors orally is clinically useless if they cannot survive intestinal and hepatic metabolism. Structural workarounds, either through biological molecular bypasses or industrial extraction, are mandatory to achieve efficacy. Beyond amino acids, citrus fruits deliver high densities of flavonones, specifically hesperidin, which independently lower peripheral vascular resistance. In a randomized controlled trial, adults consuming 500 milliliters of standard orange juice daily for 12 weeks reduced their systolic blood pressure by an average of 6.35 millimeters of mercury. When subjects consumed hesperidin-enriched juice containing twice the natural concentration, that reduction increased to 7.36 millimeters of mercury, alongside a marked decrease in arterial stiffness. This data visualization outlines the results of a crossover trial comparing commercial concentrated orange juice against freshly squeezed natural juice. The commercial product yielded significant reductions in both systolic and diastolic blood pressure, while the natural juice produced no statistically significant drops. Commercial manufacturing processes physically extract even higher levels of active hesperidin, essential oils, and pectin directly from the peel. This extraction process yields a biochemical density that natural squeezing cannot replicate. The industrial processing and extraction methods applied to a fruit dictate its final therapeutic yield, making artificially concentrated products clinically distinct from their natural counterparts. Because B's biochemical pathways dictate systemic blood pressure, introducing them into a heavily medicated patient requires strict clinical boundaries. Inside an intestinal enterocyte, we can observe the most dangerous dietary pharmacological conflict in cardiovascular medicine: grapefruit furanocoumarins initiating a mechanism-based suicide inhibition. They undergo normal oxidation, but generate highly reactive intermediates that covalently bind to the CYP3A4 enzyme. This permanently disables the enzyme's catalytic capacity. Without intestinal CYP3A4 to metabolize them, oral calcium channel blockers pass directly into systemic circulation. This loss of first-pass metabolism causes drug bioavailability to spike by over 100%. The sudden influx triggers severe hypotension and severely impairs coronary perfusion. Because this inhibition is completely irreversible, normal drug metabolizing capacity is only restored through the natural replacement of old enterocytes and the de novo synthesis of new enzymes, a process that takes up to 72 hours. Separating drug administration from grapefruit consumption by a few hours is entirely ineffective. Complete avoidance is mandatory for patients on these medications. Introducing these fruit bioactives alongside synthetic pharmaceuticals can instantly transform a standard therapeutic dose into a massive, life-threatening overdose. A similar physiological danger exists within standard cardioprotective nutrition. The DASH diet relies heavily on extreme potassium density to lower blood pressure, which presents a direct conflict for nephrology patients. Here we can compare renal filtration. Healthy kidneys easily excrete excess dietary potassium, but patients with stage 4 or 5 chronic kidney disease have lost this filtration capacity. The potassium accumulates in the blood and drives serum levels past 5.0 milliequivalents per liter. This metabolic state, known as hyperkalemia, triggers severe muscle weakness and lethal cardiac arrhythmias. To prevent cardiac arrest, patients with advanced CKD operate under strict nephrological restriction protocols. Their total daily potassium intake must be strictly capped between 1,500 and 2,500 milligrams. This requires immediate dietary swaps. Potassium powerhouses like bananas, avocados, and kiwis must be entirely removed from their diet, replaced with highly controlled portions of low-potassium fruits like apples and berries. The exact electrophysiological mechanism used to safely manage hypertension in healthy vessels becomes a lethal trigger in patients without renal filtration. This confirms that clinical cardiovascular nutrition requires the same rigorous risk stratification as any pharmaceutical intervention.